Hiya, it's Emily here today, and this is another Neonates in a Nutshell session. So today we're going to be talking about neonatal skin and infections. So this is carrying on from our skin session a couple of weeks ago where we looked at rashes and birthmarks. So today we're going to be looking at worrying skin findings, skin and infection, and then treatment. So the skin, it's the largest organ in the body, has a multifunctional structure, and it can give some clues to some underlying disease or conditions. The anatomy of the skin, so there's this picture again, so it's made up of three main layers: the epidermis, dermis and hypodermis, and then within each of these there's also some other tiny little layers. So how do we describe rashes and spots? So these words might help you to describe some of the lesions that you may come across. So things like macule, which is flat lesion, papule, which is a raised solid lesion, vesicle, which is a blister with a sac full of clear fluid, and then your pustule, which is similar but it has kind of cloudy fluid or pus. If you kind of maybe write some of these down or just keep an eye, and then later on I may refer to some of the skin findings with some of these words, so it's just to kind of have a clearer idea of what I'm describing. And then also if you do start to use some of these, then it can be quite useful for people reading notes of babies to how these rashes or skin findings look. So skin conditions in the newborn. So rashes are quite common. They're mostly benign and self-limiting. However, they can cause a lot of parental anxiety because what we know is normal, they're not aware. So it's just kind of making sure that they have an understanding and discussing this with them and letting them know what rashes are on their baby or what skin finding you've seen. So first up is acropustulosis of infancy. So as you can see, there's kind of vesicles and pustules there. Mostly pustules on the hands, feet and scalp are seen. They're rarely seen from birth and they can be quite itchy. They usually resolve within 10 to 14 days. However, they can be reoccurring. So if a baby had this, then it's just making sure that the parents are aware that this could kind of reoccur up to the age of 2 to 3 years old. And then in these pictures, so they may be a little bit difficult to see, in the top picture there, just on the baby's face and neck, and then on the bottom one near the groin, there's kind of little tiny pinprick, purpley pink rashes, and they're kind of quite flat on the baby's skin. This is petechiae rashes. So petechiae is often seen on the face from delivery due to the pressure and is no concern in a well baby. However, if it is elsewhere or spreading, then it might need to be investigated, or if the baby is unwell. So it can be a sign of abnormal clotting with low platelets. So neonatal skin infections. So these are divided up into bacterial, viral and fungal. And this is kind of dependent on the bacteria that causes or the condition that causes these skin infections. So bacterial. So this is mostly caused by staphylococcal or streptococcal infections and can cause things such as impetigo, staph scalded skin syndrome, and then omphalitis. And as you can see in these pictures, they're really quite nasty there. So staph scalded skin syndrome, it's a bit of a tongue twister. It's caused by the toxin produced by Staph aureus, and this is when it kind of gets into the skin. It can cause red blistering skin and breaks down skin layers, so you kind of get that burning effect of the skin. It starts with fever and baby being quite irritable, and then redness of the skin, and then by 24 to 48 hours some blisters might form, and these rupture quite easily, making the baby quite at risk of further infection lower down into their skin layers. So they need to be treated like burns, so watching for that fluid and electrolyte imbalance, and then treating with antibiotics. So obviously a lot of water can be lost from our skin, particularly if you don't have the right barrier. So in our preterm babies where they have immature skin or thinner layers, they're at risk of losing a lot of fluid, and this is similar to what happens in these babies. So they don't have those extra protective layers because it's kind of been sheared off. So they really need to keep an eye on their fluids and just kind of any further infection. So we might have all seen kind of redness around a cord, a baby's umbilical cord, which is normal to some extent. However, we need to keep an eye on it because it could lead to omphalitis, which is in the second picture. So omphalitis, so normal erythema is seen just a small rim sometimes around the drying cord, and this is kind of a natural process in cord separation. When we need to worry is when it becomes an infection, and this can present around day 3 of life. So there can be edema present, tenderness around the umbilicus, and there might be some discharge there as well. The infection can then extend into the abdominal wall, which can really be quite nasty, and it can lead to death. So viral skin infections. So herpes, varicella, which is your chickenpox, CMV, HIV and syphilis. So just looking at herpes to start with, so is occasionally seen and it's congenital sometimes, and the baby might have microcephaly and scars when they're born. However, most are acquired around delivery. So the baby's at risk if the mother has genital herpes, usually within the last 6 weeks of pregnancy. However, it's good to be aware that sometimes maternal infection may be silent, so she might not even be aware. She might not have any kind of herpes or anything present at that time, and the risk is related to the stage and type of infection. So it's split up into 2 categories: HSV1 and then HSV2. So HSV1 usually involves the eyes, skin and mouth. And although this isn't very nice, there is a better prognosis for this. And then HSV2 involves the baby's organs. So this can really cause quite a lot of problems and damage, and sometimes death as well. So as you can see in these pictures, the first one has kind of really sore eyes there. And then in the second picture, it's just kind of a little picture of how that might look on the baby's skin. So varicella, which is your chickenpox. So again, it can be congenital, so the baby might have it from birth, and this can cause multiple abnormalities, including skin, limb, and brain problems. So 2% of pregnancies are infected at 13 to 20 weeks, and obviously this is the developing fetus, so this is why things such as the limbs and brain can be affected at this time if this is when the mother caught it. They might not have any vesicles present at birth. If the mum knows that she has been in contact with someone with chickenpox, then she can have treatment of acyclovir, especially if she's been infected before 20 weeks. So then there's also neonatal chickenpox. So this usually occurs when there's been a maternal infection within 14 to 21 days before birth. There's a worse prognosis if the maternal rash appears 5 days before birth or 7 days after delivery. And this just means that it's obviously been more apparent during that time. If the infant then developed a rash in the first 5 days after birth, then it's likely that they did have a certain level of antibody from the mother that would have been transferred across the placenta. So that's kind of a little bit of a better outcome. So the treatment, so first off, supportive treatments as required, and then if there was maternal infection in the high risk period, then the baby can be treated with IM immunoglobulin and then close observation. If there's signs of any vesicles, then they can have acyclovir and then also immunisation of the infant. So fungal infections, the most common cause is Candida, and it can either be present straight away from birth, kind of within the first 12 hours, neonatal, so within the first week, or systemic, so these kind of as they get a bit older. So some of our preterm babies, we may see this in, especially if they've had a lot of antibiotic usage, or they've had long lines or central lines put in, especially for a long time, and they can be at risk of fungal infections. So these are some pictures of just some common causes, or kind of what fungal infections that we might see. So thrush, which is in the mouth here, and then also nappy rash, which is developed into a fungal infection or a yeast infection. Topical creams can be used, obviously depending on where that fungal infection is. So that was just a little run through of things to look out for, and obviously more serious ones and infectious ones. Of skin conditions. So the main key points to take away from this is obviously to document any skin findings on a body map. This just is then clearer for everyone coming across that baby, of what has been there and what, if anything, has changed. Document in the notes, inform the doctors if there's any changes in skin, or you found a rash, or you're just not sure. Obviously let parents know what's normal, what's not, and if the baby needs any treatment. And then in some cases, particularly in the kind of infectious skin conditions, then it's possible that you could take some photos. So obviously with signed permission from the parents, but photos allow for some comparison and monitoring. Right, so thank you very much for watching. As always, if you have any questions, then just catch one of us on the unit. If not, then we will see you next time. Thank you.